My name is Dr. Mark Socinski, and I'm the Executive Medical Director of the Advent Health Cancer Institute in Orlando, Florida. I'm also a thoracic medical oncologist and a member of our thoracic oncology program at the Advent Health Cancer Institute. One of the important questions in advanced non-small cell lung cancer today is where do you incorporate the non-chemotherapy doublet of nivolumab and ipilimumab? We had data recently from the Checkmate 227 and Checkmate 9LA, which addressed this question. One of the difficulties that I personally have in this setting is that during the course of those two trials, the standard of care changed. We know from trials like Keynote 189, Keynote 407, Empower 130, Empower 150, that a chemotherapy alone control arm or chemotherapy alone strategy is no longer the standard of care. When we saw the results of Checkmate 227 and 9LA, it was compared to a chemo alone control arm. And of course, my question is, well, we know that chemo plus IO is better than chemo alone. Is the results of Checkmate 227 as well as 9LA, which clearly showed that the Nivo-Ipi did improve outcomes versus chemo alone. But is it better than, say, the Keynote 189 or Keynote 407 or other approaches in which you're using chemo-IO combinations? And I think that that's a question that's difficult to answer because it involves cross-trial comparisons in mixed populations. I think many of us are searching for where do we incorporate Nivo-Ipi. Now, in my practice, and remember the indication for nivolumab plus ipilimumab is in PD-L1 positive patients, because that was the primary endpoint, or one of the co-primary endpoints of Checkmate 227. One of the interesting aspects of the trial is it did also include a PD-L1 negative cohort. And actually, the data there looked a little more encouraging in the PD-L1 negative population. So one could make the argument that perhaps in the PD-L1 negative population, the Nivo-Ipi would be a consideration. Having said that, we did see a year or so ago at ESMO a pooled analysis of Keynote 189 and Keynote 407 in PD-L1 negative patients. And the addition of pembrolizumab to chemo had a very significant effect in the PD-L1 negative population. So I've always argued that I'm not quite sure that that's an overwhelming argument for Nivo-Ipi at this particular time. There are patients that are very adverse to the use of standard cytotoxic chemotherapy. So Checkmate 227 and 9LA do provide evidence of the activity of Nivo-Ipi in this population. For those patients also, the 9LA strategy really truncated the chemotherapy portion to just 2 cycles. And so getting patients through 2 cycles is often quite easy. I would argue that getting patients through 4 cycles is actually really not an issue in most patients with modern supportive care. In being a good oncologist, you dose reduce and properly get the right supportive care for patients, and they can usually make it through 4 cycles without much difficulty. So I personally don't see the truncation to 2 cycles of platinum-based chemotherapy as a major advance in this setting. And I do think that there is some concern in non-small cell lung cancer when using non-cytotoxic chemotherapy regimens of a risk of early progression, which you don't see when you combine immunotherapy with chemotherapy. So I think chemotherapy does seem, in the context of immunotherapy, to have a protective effect on this early progression that you see often with non-chemo IO only accommodations. And we've seen that in a number of trials. So it is a concern to me. And this is why I favor using chemo IO strategies, whether it's monotherapy with PD-1, PD-L1 agents, or whether it's with the nivo-ipi combination. I would prefer to use the Checkmate 9LA approach, which gives a couple cycles of chemotherapy along with nivo-ipi. And I get concerned about this early progression rate. So I've been relatively conservative in my use of nivolumab, ipilimumab as a standalone regimen. I have no hesitation using it in the 9LA fashion. I do have a little bit of concern using it by itself because of this risk of early progression that's been seen in a number of trials.